We're going to be talking about the EHR incentive Medicaid program, and John is going to start off giving us sort of a national perspective and some of the things he's been seeing in the program. And then Terry is going to talk to us specifically about Vermont. Terry Bequette is the Associate State HIT Coordinator. He's had a big hand, probably the majority of the plan that needed to be submitted to CMS in order for the state to get into this program was Terry's responsibility. And Terry's been here a year. In fact, the second day he was on the job, he came to last year's summit. So we feel like this has been good training for him. Allison is with CMS in Baltimore with the Medicaid division. I don't know whether you call them divisions or not in CMS. And he is the Medicaid HIT coordinator, which includes responsibility for reviewing the plans that Terry has submitted, as well as other states.
I like John. Thank you.
And John has worked for the Ohio Medicaid program, so he comes with some real on-the-ground experience and has done graduate work at Emory University. So, John, we're going to start off with you. So, what I have in mind here is about 20 minutes on John's presentation, 15 to 20 minutes on John's presentation, 15 to 20 on Terry's, and then try to allow at least 15 minutes for questions. So, John.
Thanks. All right, thank you, Paul. Now, I'm kind of pinch hitting for someone who, because of family circumstances, can't be here today. Thomas, Tom Novak. Thank you. God, it slipped my mind. Anyway, some of you may be more familiar with Tom. He's based out of Philadelphia, and he's the high-tech regional coordinator, or the regional high-tech staff that, again, some of you may be working with or may be familiar with. But again, Allison, CMS, Center for Medicaid CHIP Survey and Certification, Data and Systems Group, Division of State Systems. There are many bureaucratic layers, but that's the official title of all the bureaucratic units that I belong to. And I'm going to give the Medicaid EHR incentive program update from the federal perspective. So we'll paint kind of the big picture of the Medicaid EHR incentive program. And we'll also talk about the status of the incentive programs right now regarding states that have launched, providers who have registered, payments that have been issued, and then, as Paul said, Terry will sort of drill down to the Vermont level perspective. So, okay, so, and actually big chunks of this presentation have largely already been discussed if you've been in the last two sessions in this room, but again, I'm going to go back through all of it because I think I see some new faces here. So starting off, who are the Medicaid eligible professionals that can receive incentive payments for adopting and meaningfully using certified EHRs? There are 5 categories of eligible professionals: physicians, whether MDs or DOs, dentists, nurse practitioners, certified nurse midwives, and one that's been the talk of the last session, which was physician assistants who work in federally qualified health centers or rural health clinics that are led by a physician assistant. There are then also hospitals that can qualify for the Medicaid EHR incentive payments. The hospitals include critical access hospitals and cancer hospitals and children's hospitals. So besides just being an appropriate type of provider to qualify for an incentive payment, you also have to demonstrate, providers have to demonstrate that they are serving a significant population of Medicaid consumers. So they have to be more than just one of these provider types listed. They also have to, which we will look at on the next page, they have to have a minimum Medicaid patient volume. So as you can see, for most of the Medicaid eligible professionals, the minimum Medicaid patient volume threshold is 30%. That's true for physicians, for dentists, for certified nurse midwives, for physician assistants when practicing in an FQHC or RHC that is led by a physician assistant. The one group that differs are pediatricians, sort of a subgroup of the physicians, And if they have a 20% Medicaid patient volume, then they can actually qualify for a reduced Medicaid EHR incentive payment. Then hospitals, acute care hospitals, including critical access hospitals and cancer hospitals, have to have a 10% Medicaid patient volume. Then for children's hospitals, there is no minimum Medicaid patient volume, so they kind of stand out because of the fact that they don't actually have to verify a minimum Medicaid patient volume. In the column on the far right, there is another exception that's applicable to eligible professionals who practice predominantly in an FQHC or RHC. Rather than having 30% Medicaid patient volume, EPs practicing in an FQHC, practicing predominantly in an FQHC or RHC, can have 30% needy individual patient volume. And we're going to talk about that in more detail, actually, I think on the next slide. The 30% needy individual patient volume is not an option for hospitals. That only applies to, again, eligible professionals who are practicing predominantly in an FQHC or RHC. So next slide. So here we are actually going to define a couple key terms here. One is practices predominantly, and the other one is needy individuals. Again, both these terms came up in the prior two sessions that I've been up here on this panel for. So an eligible professional is considered practicing predominantly in an FQHC or an RHC when the FQHC or RHC is the clinical location for more than 50% of the EP's total Medicaid patient encounters over a period of 6 months in the most recent calendar year. An EP who is practicing predominantly in an FQHC or RHC must have a needy individual patient volume of 30%. Needy individuals are defined as patients with coverage through either Medicaid or the Children's Health Insurance Program, patients who are furnished uncompensated care by the eligible professional, or patients who are furnished healthcare services by the EP at either no cost or on a sliding scale. So it's actually a broader category than just Medicaid patient volume, that it encompasses the Medicaid patient volume as well as CHIP, uncompensated care, and sliding or no-cost care. Okay, something else Travis touched on earlier in one of the meaningful use sessions, or at least in the conversation that spun out from that session, and that is that EPs cannot be hospital-based in order to participate in the Medicaid EHR incentive program. This restriction does not apply to EPs who are practicing predominantly in a federally qualified health center or a rural health clinic. So an eligible professional is considered hospital-based if 90% or more of his or her services are furnished in an inpatient hospital setting or an emergency room setting. And this can be determined, since it will have to be determined by states, by looking at the place of service codes on the eligible professional's claims. So an inpatient hospital setting corresponds with place of service 21, place of service code 21, while an emergency room setting corresponds with place of service code 23 on a claim. Okay, payments. So the maximum incentive payment that an eligible professional can receive across 6 years of participating in the Medicaid EHR incentive program is $63,750. And this table just breaks it down in a lot of detail, showing the actual amounts that an eligible professional would receive depending upon when they begin program participation in the Medicaid EHR incentive program. So in their first year, an eligible professional who is either adopting, implementing, or upgrading certified EHR technology, or if any state actually winds up allowing this for first-year participants who is demonstrating meaningful use, the first-year payment is the biggest. It's $21,250. Then for each of the next 5 years that an eligible professional participates, that EP would have to demonstrate meaningful use. And for each of those years, the EP would receive $8,500 a year. So again, you can see from the row at the bottom, that adds up to $63,750. Something else that separates the Medicaid EHR incentive program from the Medicare EHR incentive program is even if an EP initiates program participation after 2012, the actual total amount of the incentive payment does not go down. So you can see if an eligible professional were to initiate in 2013 and receive 6 consecutive payments for 6 consecutive years of participation in the Medicaid EHR incentive program, they would still receive $63,750. If they start in 2015 and adopt, implement, and upgrade the first year, then demonstrate meaningful use through all the years through 2020, they would still receive, again, $63,750. And this is just one of the many things that separates the Medicaid EHR incentive program versus the Medicare EHR incentive program. The Medicaid program, it really does maximize the benefit to participate in the program, and you have more options, or you have more time, I guess I should say, in order to get that full $63,750, whereas the Medicare EHR incentive program, the maximum benefit across 5 years of participation is $44,000, and if you start after 2012, it already starts to go down to, I think it's like 30-something thousand, then 20-something thousand. It just kind of decreases each year that you delay participating. All right, so we'll talk in a little bit more detail about adopting, implementing, and upgrading certified EHR technology, and we'll briefly touch on meaningful use, although Travis has already discussed that in detail in the previous sessions. So for the first year of an eligible provider's participation in the Medicaid EHR incentive program, they can receive an incentive for either adopting, implementing, or upgrading certified EHR technology. They don't have to demonstrate meaningful use in this first year. There is no EHR reporting period. It is limited just to their first year participation. Every other year, they do have to demonstrate meaningful use. And again, the first year incentive payment is the $21,250. So just to kind of flesh out or better define adopting, implementing, and or upgrading certified EHR technology. Adopting just means that they've acquired the EHR technology. They could be installing it. They've acquired it whether they've purchased it or they've licensed for it, or they have a contract agreement that they're using this certified EHR technology. So they don't actually have to have purchased it, again, if they have access via a contract or license agreement. That's also considered adopting EHR technology. Implementing EHR technology just means that they are starting to train staff, or they're starting to integrate use of the EHR into the eligible provider's workflow. Upgrading certified EHR technology means that you are actually taking, you may have a module or modules of EHR technology that aren't certified by the Office of the National Coordinator and aren't on the certified health IT products list. But if you upgrade your EHR technology and you actually add on modules that make it a certified, excuse me, that make it certified EHR technology that meets the standards for health information exchange and the other standards that the ONC defines in their rules, then that is considered successfully upgrading to certified EHR technology. And again, you can receive an incentive for any one of those, but not for all three of those necessarily. So this next slide, okay, that's everything high tech, how the pieces fit together. So what I wanted to point out in this slide is the important role that the Medicare and Medicaid EHR incentive programs play, but especially the important role that the Medicaid EHR incentive program plays in all three of the principal activities that are going to be, that as described in high tech, that are going to be driving improved individual and population health, increased healthcare transparency and efficiencies, improved ability to study, and improve care delivery. Those three main activities are providers adopting EHR technology, providers meaningfully using EHR technology, and then providers actually exchanging health information via health information exchange. So unlike the Medicare EHR incentive program, as we've already discussed in a little bit of detail, the Medicaid EHR incentive program actually facilitates EHR adoption by paying that first year incentive for adopting, implementing, or upgrading certified EHR technology. Medicare does pay for meaningful use of certified EHR technology, but so does Medicaid in the 2nd through 6th years of provider participation in the program. And then for health information exchange, states actually draw down 90% federal high-tech funds to develop and implement and administer their Medicaid EHR incentive programs. They can also use this federal funding to develop a health information exchange. Again, at the state level, and along with other payers and providers, states can contribute some of this high-tech funds towards developing the statewide health information exchange. So again, this really does show off how the Medicaid EHR incentive program very specifically touches on all three of the main activities for improving health outcomes and for reducing costs and reducing redundant tests and things. Okay, so at a glance, as of September 5th, so as of Labor Day, right, this past Monday was the 5th, 27 states have actually launched their EHR incentive programs, which means that their programs are now open for provider registration. The 4 states who just launched on September 5th were Georgia, Illinois, Florida, and Oregon, actually. Vermont is soon to launch next month, actually on October 3rd. Vermont will join several other states in launching their programs. We've had states sort of trickling in and launching their incentive programs at the beginning of each month in 2s and 4s ever since the first 11 states launched back in January. We actually have a tool on the CMS EHR incentive programs website that shows the anticipated launch dates of the different states, as well as the states' health IT websites. Even more exciting than the 17 states, than the 27 states that have actually launched their incentive programs are the 17 now that have actually dispersed incentive payments to eligible providers. And we're going to drill down in a bit more detail in just a second, talking about which provider types and how much each provider type has actually received as a result of adopting, implementing, and upgrading EHR technology. Additionally, over $384 million has been awarded to states for planning and administration of their EHR incentive program. I mentioned a short while ago that states can use high-tech funds to foster health information exchange development. Well, it's from these $384 million in funds already awarded that a state, if they want to participate in the development of a statewide health information exchange, again, they can use those administrative funds to do that. Okay, so how's it going for Medicaid? So active registrations as of September 1st, 37 Medicaid-only hospitals have registered for the for Medicaid incentive program. By Medicaid-only hospitals, again, we're talking about cancer hospitals that have 10% Medicaid patient volume, acute care or critical access hospitals with 10% Medicaid patient volume, and children's hospitals. Actually, I guess, that would just be the, typically that would just be the cancer hospitals and the children's hospitals, because the acute care hospitals would actually fall into the next category, which is the 1,933 dually eligible hospitals eligible for incentive payments under both the Medicare and the Medicaid EHR incentive programs. So again, 1,933 hospitals have successfully registered. Then we have 17,181 Medicaid eligible professionals who have successfully registered. Again, that's getting back to the physicians, the nurse practitioners, the certified nurse midwives, the dentists, and the physician assistants practicing under those criteria that we specified before. The 17 Medicaid agencies that have dispersed incentive payments as of September 1st have now paid more than $389 million. And this is quite an increase from July 31st, the last time we released public figures about how much had in Medicaid EHR incentive payments had been dispersed by the states. At that point, 14 states had dispersed about $250 million. So now 17 states have dispersed $389 million. And since this is only 17 states making payments, this number will continue to grow and will likely grow quicker as more states launch their programs. I might have mentioned already, we right now have, it's about 5 or 6 states that are, including Vermont, that are intending to launch in October. So this cuts and kind of recuts the numbers again. So as of September 1st, 2011, 294 dually eligible hospitals have been paid more than $262 million. 15 Medicaid-only hospitals have been paid nearly $33 million. And 4,463 eligible professionals have been paid almost $94 million in Medicaid EHR incentive payments. We've been talking a lot about the incentive payment that an eligible professional would receive. Again, whenever I was talking about the $63,750 that an eligible professional could receive. Well, Medicaid hospitals, the ones that have received incentive payments so far, the average year one incentive payment for a Medicaid hospital who has adopted, implemented, or upgraded certified EHR technology is $955,000. This amount, okay, again, that's the year one payment. Typically, what happens is a state will disperse the Medicaid EHR incentive payment for a hospital over a period of 3 to 6 years. Most states have opted for a 3-year disbursement of the Medicaid incentive payment, to where 50% of the calculated payment is paid in the first year, 40% is paid in the second year, and 10% is paid in the third year. Several hospitals are actually doing Medicaid first, since it's the lower threshold, since they can, again, qualify just based upon adopting certified EHR technology, and then they're going to come back to demonstrate meaningful use under the Medicare EHR incentive program. Okay, so CMS provider surveys have demonstrated that just since last summer, when the EHR incentive program's final rule was released, overall awareness of both the Medicare and Medicaid EHR incentive programs has actually grown fairly significantly. Awareness, of course, of the incentive programs is an important milestone before someone can actually apply and be eligible and actually receive the incentive payment. So it's good that we're, putting these programs out on providers' radars. This increase in awareness is also due in part just to the outreach and communications efforts of both the federal government and of the states, who, again, actually administer the Medicaid EHR incentive programs under CMS guidance. Okay, so the provider surveys also show that the vast majority of providers plan to register for the Medicare and or the Medicaid incentive programs, with 92% of hospital execs registering or planning to register, 82% of the mid-level practitioners, nurse practitioners, physician assistants, et cetera, planning to register or having registered, and 71% of physicians. Even some of the providers in the middle category, those who don't plan to register, have been sort of wavering in their resolution to not register. So word is out. The federal government via the states is paying out these Medicaid EHR incentive payments, so even the doubters are, to a certain extent, coming around. Challenges at year one, and again, by year one, we're just talking about in the last year since the Medicaid EHR incentive programs launched for certain states and since the final rule was released. So states actually have to make the eligibility determinations for providers, including verifying whether a provider, a Medicaid eligible professional, has the 30% Medicaid patient volume. But how is a state supposed to do this when most states don't have all payers' claims databases to verify the total patient population of a provider, and then figure out, if they actually have 30% Medicaid patient population? So there are some shortcomings in the data sources that states are using right now to verify provider eligibility. And most states, there was an OIG report actually released in July that looked at 13 states who already have EHR incentive programs. Most states are going to actually put off verifying about half of the eligibility criteria. They won't be doing it prepayment, they'll be doing it post-payment. So again, CMS is working with states to actually help them have data sources that are auditable and that they can use to verify all the eligibility criteria for a provider prepayment, which of course is much safer than you're not, doing the pay and chase thing. So for stage 2, this is something that was already discussed. The ONC this morning, and again with Travis, the ONC Health IT Policy Committee recommended delaying the implementation of stage 2 of meaningful use until 2014. Such a delay would not necessarily have a direct impact on Medicaid providers, who would have already started stage 2 in 2014 anyway, since at the earliest, Medicaid providers can adopt, implement, and upgrade EHR technology and receive an incentive payment in 2011. Then in 2012, those same providers who AIU'd would demonstrate meaningful use for a 90-day period in stage 1. Then in their third year, which by that point is 2013, they would demonstrate stage 1 meaningful use for the entire year, for a 365-day year. So there's sort of a built-in cushion that is pushing the stage 2 back anyway for Medicaid providers, even without the Health IT Policy Committee's recommendation to push it back. Let me summarize here a bit. So we're looking forward to a release of the Notice of Proposed Rulemaking for Stage 2, which we anticipate will be published in the Federal Register around January, the NPRM will, and then that's going to be followed by a 60-day period, 60-day public comment period that CMS will then take back and digest the comments and the feedback. And we anticipate actually releasing the final rule for Stage 2 sometime in late spring or around June or so. And let's see, on the horizon, I'll be quick about this. So more states are making requests for health information exchange funding. Again, they're requesting the 90% federal match so that they can contribute along with other payers and providers to the development of a statewide health information exchange. We're also trying to help the states align. Well, let me back up. We know there are many challenges states are facing. Besides just the budget crunch that most states find themselves in, states are also facing multiple health IT initiatives, whether it's the replacement of their MMIS legacy system or ICD-10, or now all the Affordable Care Act initiatives that are coming down the road, such as eligibility and enrollment system simplification. So we are working right now to help states sort of align or find even synergy with these multiple efforts and not necessarily duplicate efforts while they're kind of walking down the road trying to achieve these multiple health IT initiatives. 30 seconds. Got it, okay. And we already said, let's see, yeah, okay, release of the Stage 2 NPRM. Okay, resources. The first one's a very important one. That's the CMS EHR Incentive Programs website. You can also follow us on Twitter. There are, at the CMS EHR Incentive Programs website, there are FAQs. You can also sign up for our email listserv, which we send out important information about states launching and sort of other milestones that the incentive programs are achieving or nearing.
Well, thanks, John. You actually covered about a third of mine, and I appreciate it. I really do. It's great. So I'm just going to start moving right through here. So I was going to talk about Vermont's particular implementation of the incentive payment program. We'll talk about the requirements, registration and attestation, the payment process itself, appeals, and how you can get some help with that. So John pretty much covered this. You know, what do you need to do to be able to satisfy the requirements for an incentive payment? And I will just reiterate at the bottom line of that in the first year for the Medicaid incentive payment in Vermont, we'll only accept AIU, adopt, implement, or upgrade. We will not accept meaningful use. Our system's simply not equipped to process any data that you would be trying to put in. So, and John effectively covered, I believe, who are eligible professionals and eligible hospitals, so I'm going to move through this slide as well. And John covered eligible professionals being hospital-based and in emergency rooms. One thing, the second point of this thing is that an eligible professional must be enrolled as a Vermont Medicaid provider without sanctions or exclusions, obviously, and we will be checking for that. So if you happen to not be enrolled for some reason and you want to apply for an incentive payment in Vermont, you should do that. Get yourself enrolled. This is what John covered on the hospital-based EPs, and codes 21 and 23 are the relevant codes there that apply to that. John also covered practicing predominantly in an FQHC or an RHC and providing care to needy individuals. So I think I'm consistent with his message on that. How am I doing so far? Okay. I know I'm the only thing standing between you and an early out. So, physician assistants. So a physician assistant is eligible when they work at an FQHC or an RHC that is so led by a physician assistant. And CMS was asked the question a long time ago, well, what does that mean, so led? And it means specifically when they are the primary provider in a clinic, or they are the clinical or medical director at a clinical site of practice, or they happen to be the owner of a regional health center. So those are the conditions that a PA would have to satisfy. Now, we'll talk a little bit later, but if an FQHC or a clinic is using the group data as proxy that John discussed in a previous session, even though the PA may not be an eligible professional and to apply for an incentive, their Medicaid encounters would certainly count towards the total. So, another requirement is that you have to have a federally certified EHR system. So here's a link that would take you to the CHAPL, which is the Certified Health IT Product List that's operated by ONC. So if you can't find your system and come up with a 15-digit number, then you may not have a certified system. So you need to be sure that you pull off an ID number from this site, because that's what you will have to enter into the Vermont application when you get there. And you want to make sure that it's certified by an authorized testing and certification body as well. John covered AIU, so I don't think I have to cover that. There is no EHR reporting period required for the first year. Just pick a 90-day period from the previous calendar year for your Medicaid threshold, and that's all that's required. That and some proof of purchase. So you have to like tear off the box top and send it in to us or something. We'll talk about that a little bit later. Last point on this, and this was talked about by Travis earlier, that states have the option of making a change in meaningful use in terms of the public health related objectives, but as Travis said, no state has, and Vermont is not going to either. So whatever you see published with respect to meaningful use stage 1 at the federal level, that's word for word what's happening in Vermont. The bottom line on this is that we expect some proof of purchase. So that would be a receipt or an invoice or a contract, something to demonstrate that you've actually invested in a system or you're about to. And we'll have a mechanism where that could be hopefully scanned and emailed into us as well at the time that you make your attestation. John covered patient volume. This was a cut and paste actually from the CMS presentation that I pulled off their website. So, and this is a simple, how do you calculate 30%? Okay, you include your Medicaid patient encounters and divide by the total. And the only reason I actually included this is that in the numerator it's in the preceding calendar year. So if you're applying for hopefully those who are ready when we do launch and want to have 2011 be their first payment year, so you're going to be applying late in the year, you would still pull data for your threshold calculation from 2010. So it's the preceding calendar year that counts. John discussed the definition of a patient encounter, so I don't need to cover that either. So now we can talk about the incentive payment program process, okay? This is more of the mechanics of what's going to happen here in Vermont. And as Travis said when he described the Medicare incentive payment program in an earlier session, for Vermont, for the Medicaid program as well, you start by going to the National Registration and Attestation site, and this is the link for that. And there you will provide some fundamental information, your name and your address and your NPI and your tax information number. And then you choose, okay, are you applying for Medicare or Medicaid? And if you choose Medicaid, it wants you to select a state from a drop-down list. And Vermont's not in that state yet. So I would suggest that if you want a Medicaid incentive payment, that you hold off until we're closer to launch, and then some short period prior to launch, Vermont's name will actually appear in that list and you'd actually be able to select it. But otherwise you'll be stymied and you'll have to go back in at a later date. So you'll need your EHR certification number as well and your email contact information. All of this is at the federal level, and then it's going to be electronically transferred to us so that we're going to know that you're now starting the process. You would receive, after a few business days, 2 or 3 or 4, an email from us saying, Okay, great. You've been, you have successfully registered at the federal level, and now please come into the Green Mountain Care portal, where you will find a link into our attestation system. So, and we're calling that system MAPPIR, M-A-P-I-R. It happens to stand for, it's not important that you even remember, but think MAPPIR, okay, that's good. It stands for Medical Assistance Provider Incentive Repository, because basically it's a repository of all of the information you'll be putting in, and we'll be able to keep it year after year for comparing for your subsequent payments and stuff like that. It'll include attestations, appeals, oversight functions. You will use your normal Green Mountain Care Internet portal address and password to get into this system. So again, if you're not currently registered with as a Medicaid provider in Vermont, this is where you would start that process as well. You can delegate someone to enter data into the portal for you. So if you're a practice that has several providers who may be wanting to attest, one person could be designated to do that entry for all of the providers. And John, I want to invite you to stop me if you're hearing me say something I may be off. Sure. Okay. I won't feel offended at all. Yeah. So MAPPIR will look for a registration record from that federal level, and then the application process begins. As you go through this process, you'll be verifying the data that we feed back to you on screens, and you'll be entering additional data elements, and finally you'll be saying, yes, that's everything I want to do, and you'll be actually attesting, which is the equivalent of an electronic signature. We're gonna ask you some basic things about your patient threshold. You're gonna say, well, here's the start date of my 90-day period. Here's how many Medicaid encounters I had. Am I using group data or individual data? Here's my total encounters. I can digress for a second. John mentioned that a lot of states are having trouble validating the denominator. Well, Vermont, we actually have an all-payer claims database, so we have the capability to look at a provider and determine how many total claims he's had in that 90-day period. So that's a reporting function we're working on, but we actually have a data source to use for that. But then what we're going to do after you've done this attestation is review it. So there is a hands-on. It's the payment part, the approval part is not automated. We want eyes on to look at the data, confirm that the encounter data is accurate and appropriate. We're using close. You know, we don't expect that the number of encounters you submit would exactly match what we might pull out of a report in our Medicaid system, but close counts. And then we would inform you, you would get an email that would be generated by the system that you've either been approved or denied. And you would also, if it happens to be denied, it's more than, I can't imagine it's probably based on your threshold data. It may be that you have a sanction against you as a provider or something like that, but odds are it's that you've missed something on your calculation of threshold data. And there will be an appeal process, but informally, I mean, there'll be a number that you can call and we can talk through things as well. The payment when it comes to you would be a standard Green Mountain Care payment, so there'd be a remittance advice that would explain it. If you happen to be in a situation where for some reason you owe Medicaid money because of overpayments or something like that, just as the federal government would, you know, do a true up on an income tax refund or something like that, we will do something like that as well. So, but you would get credit for the full thing. You would also see that on your annual 1099 as well. So yes, this is taxable income for people if you're a taxable entity. We would contact you if we have any questions, and I mentioned the appeals process. And you can reassign your payment to your employer or a contractual entity that's allowed to bill and receive payments for you. So I get asked this a lot, you know, how do we make sure that all our providers are going to actually give their payments to us? and that's between you and your providers, if you happen to be a hospital or a group or something like that. The state's not going to get in the middle of that, so you just have to work that out. So in terms of preparation, you would make sure you've got a valid email address, and that you've got a user ID and password. The NPI, tax information number, have to match with the federal system, and some proof of acquisition. Hopefully on our website, when I get that set up, we would have a sample mapper application that you could at least walk through. You wouldn't be entering data, but you'd be walking through it and seeing it. The mapper system itself, okay, this is very much like working through TurboTax is the analogy I like to use. It has tabs that you walk through, and so you start with the Getting Started tab, and then we check your national registration contact information, and you say, yes, that's correct, and you get back a box that says, with a green check in it, okay, you're good to go, let's go to the next step. We check your eligibility, so this is, what provider type are you attesting to be, or eligible hospital or whatever. We check your patient volumes, and then finally the attestation itself, and then just like TurboTax, there's a final review. And when you do that, you will see all of the information you presented kind of laid out on one long screen that you can scroll through. And I would probably encourage you to print that, because we don't actually offer a printout to you or anything like that. So, but that's where you might want to print it. And just like with anything else on the internet, don't use the back button or you'll be starting over. But you can, in fact, your information is saved once you're in the system, so you can leave it at any time. You can come back and you can start where you were and continue on. So it has that going for it. Just as an example, when we're trying to determine if you've acquired or adopted or implemented or upgraded a system, this is an example of the kinds of questions. If you said, I've implemented, we would ask you these questions, and you would indicate for each of these 8 or 9 things here that you've either planned it or you've completed it, and not necessarily all of them, but what's your level of progress with these things? So in this instance, this provider said, well, we've planned our workflow redesign and we've completed our software and hardware installations and we're doing e-prescriptions, okay? And then you get back a confirming screen from the application that would just validate what you put in. I think I've covered everything on this slide. Once you finally say this is it and you push the final submit button, you can't go back in and make any changes after that point. And I can certainly imagine a situation where someone would say, oh gosh, I meant to say 2,900 instead I said 290 encounters or something like that. You could call us, and we have an administrative backdoor, so we have the opportunity to help you out if you think that some information you put in needs to be corrected. But you yourself are going to be locked out of it at that point in time. So we've been talking about October 3rd. It's important because if we miss October 3rd, then we have to wait till the first Monday of the following month. We can only launch on the first Monday of the month. So I'm still very hopeful that we will launch on October 3rd. John and I have some things to discuss about that. We have a lot to do. We have a lot of website information we have to put up, and we still have to complete our provider manuals for hospitals and providers. We're in the process of doing system testing now. The Mapper application itself is a web portal software development that we participated with 12 other states because we all have the same common Medicaid system as a back end. So we get the core functionality, and then we have to develop the specifics of tapping into our Medicaid system to pull out reports and stuff like that. One option we have is to launch, but not necessarily let you start a testing on the first day. But that would give us some play time between October and November. So there are also grace periods for when you do a test. For instance, hospitals function on the base of a federal fiscal year, which ends on September 30th, and the grace period is 60 days. So A hospital that's ready, and I know of one, would definitely want to attest no later than November 29th or something like that, 60 days after the end of the federal fiscal year, so that 2011 could be their first payment year. For other eligible providers, it's based on a calendar year, and you could attest as late as toward the end of February 2012 for a 2011 first year payment. So if you do think you're going to be ready to attest, and I have heard from several people, I'd like to know it. I'd like to know what's liable to be in the queue on day one, because it will help me to gear up the amount of administrative support and figure out how much overtime I'm going to have to pay for. So that's my contact information, and you can let me know. And Steve, these presentations are going to be on the website, or okay? These are some links. So there's a link to the Office of the National Coordinator, where you'll find a lot of valuable stuff from the high-tech perspective. John's link is repeated here for the CMS, EHR, and Senate payment site, and that is a tremendously rich site of information, and it's well organized. It has a left-hand column that has topics, and then each topic is very rich, and you can actually walk through an entire Medicare application for meaningful use, for example, that's eventually would be very similar, excuse me, to a Medicaid application. So I would encourage you to spend some time there if you haven't. There are a lot of frequently asked questions. I think, I don't know, 140 or so, and growing. So VITL's website is on here, and they have a lot of good information, including webinars that are related to this topic. Vermont has a healthcare reform website, hcr.vermont.gov. That's where I will probably be putting up some web-based material to help you through this process. DEVA has a website, but I'm planning to use the healthcare reform website. And then the Green Mountain Care portal site is there as well. And then for contact information, I've got myself and Carol Kolchik and Paul Forlenza at VITL. And I will mention again, as Carol did earlier today, that VITL as the REC, in particular the Regional Extension Center, they're very geared up to help people get into this process and get ready with the fundamentals of getting their EHR systems installed and ready to go. And so now we're at questions.
So the website where all these presentations are is vital.net/speaker. Is that right, Steve? And I think most of them are up. It may be 24 hours before John's gets up, just because we didn't have it in advance. So we have a little time for questions, and we have 3 ringers who are in the audience, and I'm going to ask them not to ask questions unless we run out of questions. And that's the 3 young ladies in the front who are implementation specialists, Priscilla, Jen, and Betsy. Question?
Assuming an October 3rd go date, and we press the submit button on October 3rd or October 4th, and you do your review and everything looks fine, when do we get the money?
Well, I think we have a requirement to get your money fairly soon, okay? And I think it's like 45 days that we're supposed to have the check out to you.
Right, 45 days from verifying the attestation.
Right. So we will first do a verification phase, but once we approve it, it'll basically go into, we're trying to not make any changes to the Medicaid system. So it'll go into the whole payment processing, check writing, payment aspect of the existing Medicaid system. That's how the money will be processed and find its way out to you.
Question in the back.
Does keeping a certified EHR updated, suppose we get a certified EHR this year, we do AIU, we keep it updated to accommodate meaningful use 2 or whatever, and a new provider joins our FQHC next year, do they still attest as their first year if they have not previously attested somewhere else as AIU?
a really good question. Yes, actually they would. They would attest as if it's their first year. You're right.
And do all EPs in an FQHC need to attest for the same 90-day period?
If you're using the group data, yes, it has to be the same 90-day period. If they're doing individual, then they can choose any start date individually.
Okay. I have some more, but there are other people.
Thanks. Question up here, I think, or
Up here? Yeah.
somebody had their hand up in front here.
Do all flavors of Medicaid count? Dr. Dinosaur, Primary Care Plus, straight Medicaid?
Yes, in Vermont, anything where Medicaid made part of the payment counts.
And that includes CHIP.
Yeah. Per capita or ad valorem, in other words? Is it the total amount or the individual claims?
No, you're counting encounters, and so
Okay,
a Medicaid encounter
Is
is
a
one where
Medicaid
Medicaid
encounter.
made some part of the payment, some or all of the payment.
Question in the back, I think.
Right
Yeah.
here, too.
Here's one.
Well, he had his hand up first. You guys answer the questions, I'll referee.
I think it's fairly short. You had mentioned a three-part payment for hospitals. That's just a hospital thing? Is that not the same
Right,
for
right.
primaries?
That's how the hospital incentive payment gets dispersed, and that actually depends on the state. The state could also disperse it across 6 years. Most states are dispersing the hospital incentive payment, though, across 3 years. That 50% the first year, 40% the second year, 10% the third year. That does not apply to eligible professionals. Again, it's just that set amount that eligible professionals receive. $21,250 their first year participation, $8,500 each successive year that they participate in the Medicaid program.
And Vermont is making hospital payments on a 3-year basis as well.
Question here?
I got thrown for a bit of a loop when I saw the numerator.
Just once you got thrown?
Well, because I thought I understood the numerator, but then it said in the preceding year. So just to be clear, if I attest on October 3rd, then I have to pick for 2011, then I have to pick a 90-day date in 2010?
Yes.
Okay. So then the other question that I had, which is related to this, and I know you mentioned it briefly, if we're doing the AIU in year 1, do we do 365-day reporting year in year 2 or 90-day year?
90,
And then 365.
yes.
And that's for stage 1, and then stage 2 is 1 year, 1 year, 1 year, or do we start over?
No, there's no, right, it's 1 year, 1 year, 1 year.
Okay.
Right.
More questions? I saw some hands in the back.
There's one there.
I have a lot of questions about obstetrics and the fact that it's a global bill and it will be a place of service with the hospital, but the majority of the care takes place in the practice. All the antepartum and postpartum care do not get billed out. So how will you determine my volume?
Well, that would actually be up to the state. So, again, so claims are reviewed to determine whether or not, a provider is hospital-based. So you're saying most of the services would indicate.
You do not bill the
Right.
antepartum care does not go to the state to say you saw the patient today, you saw the patient in 2 weeks and
Right.
whatever. So if I have a patient who's had 17 visits in the office, delivers in the hospital, how do I qualify for the state volume?
Right, and we've had a question like that before. That's a tough one. Actually, weeding out. Yeah, sorry, that's the best answer I have. Right. I know. That's something that we have actually been addressing with states, how they can weed out the actual, encounters, so to speak, from the payment. I don't think we've actually landed. I think there's some variation depending upon the situation, but that is something that we are looking to address in stage 2 at this point. But right now, I don't think we've addressed it in stage 1.
So are you saying that we won't be able to even go into the program till you?
No, no. It actually is dependent upon the state. If the state can find out, we've been kind of pushing that back on the states. If the state can find out,
Carrie, can you answer that?
I can't right now. I'd like you to see me afterwards so I can get your contact information.
Sure.
No, let me borrow that for a second. So, but I think the important thing to, there are two different things we're talking about, right? So there's two thresholds, one of which is 90%, and that's the hospital-based one. And like global billing for surgery, the antepartum care, you bill separately for the initial determination and the initial visit, and then after they're pregnant, you global bill everything else, right? No, but the first visit, they show up and you don't even know they're pregnant. That one's billed separately, right?
Only if you do an ultrasound or something like that. The very first one, as long as you determine they're pregnant, that starts your global period right then.
So you don't have the surgeon solution, but it is, the surgeons say is, the visit they determine you need surgery isn't in the global bill. So the worst case is it's 50%, which is a heck of a lot lower than 90. But yeah, if you actually have a situation where that would, to get into 90, if you run into a 90% problem, that would, CMS would like to hear about that too. I mean, since you're talking about this, it's obviously a Medicaid thing, but that would be the first time somebody actually ran into a billing problem with the 90%.
Isn't it great that there are 4 males up here answering these questions? One.
Females I've asked could answer it either.
Oh, great. Thank you for saying that. One more quick question.
I'm part of a 5-provider practice that is not with an FQHC, but is thinking about joining an FQHC. If we decide to go ahead, or should we go ahead and attest as those 5 separate providers, next month? But what if we join the FQHC in December or January 1st? What happens, and what should we do? What do you recommend we should do?
sure. So for this first year, you would attest to AIU, no EHR reporting period. And you would, so you're saying, what if you were to join a FQHC like in December or January or something? So then for 2012, you could attest to meaningful use for 90 days. And potentially you could actually, in 2012, because you actually joined the FQHC actually still in 2011, right? You could still attest to meaningful use for 90 days based upon a 90-day period.
Okay.
Yeah.
And then once we become part of the FQHC, though, our numerator and denominator, how we get those numbers, does that change?
Sure. It depends upon what the solution is, kind of that's agreed upon by the FQHC and the providers. Something that we talked about in the previous sessions today is the group proxy, or the FQHC, the clinic proxy, where the total Medicaid patient volume for all the providers in the FQHC is added up, and it's divided by the total patient volume across the FQHC, and then for the eligible providers at that FQHC, they can use that group proxy. If some of them, that would be a solution for, like, if some of them were a little below 30, but others were well above 30, all of them could potentially qualify if the group proxy was over 30. If one provider, though, says, if one FQHC provider says, no, I don't want to use the group proxy, then none of them can use the group proxy. It's all in or all out. Does that make sense?
And then just one last thing.
Sure.
We have a different EHR than the other practices do. Does that have any effect on qualifying and meaningful use?
You have a different EHR? Is it a certified EHR?
It is.
Yeah,
it is,
no.
but it's just different.
Sure, no.
Okay.
No effect.
So I know everybody has lots of questions. I have about 22. And what I would say is these gentlemen will be up here for a couple minutes afterwards. So thank you for coming, and thank you, the speakers.